Hey guys, Miss Hill here, and we are going to proceed with this lecture, Individual Module 5.3, Lecture 1, and we are going to be talking about postpartum care and continue on into postpartum depression. So let's first talk about postpartum care. Here are your outcomes. And we're going to first start talking about some key terms. The first key term that we're going to talk about is puerperium, and this is the period of about 6 weeks after childbirth during which the mother's reproductive organs will return to their original non-pregnant condition. Involution is part of what happens during the puerperium in order to get the uterus back to what its pre-pregnant state was. So involution, the definition of that is the shrinkage of an organ whenever it's inactive. So, for example, the uterus after childbirth. Okay, moving on, let's talk about subinvolution. And this is a condition, a medical condition, in which after childbirth, the uterus does not return to its normal size. So it does not contract well enough in order to get back to where it belongs. The fundus, we all should know what that is at this point. That's the top portion of the uterus. That's where you do your fundal massage and assess the mom's involution, the size of her uterus, and the placement of it. Lochia is the bleeding that moms have after delivery, and we should know there are 3 types of those, which we'll go over in a minute. Uterine atony, that just means the uterus, a uterus that is unable to contract, so a uterus that has no tone. Diastasis recti abdominis, this is the condition in which the recti abdominis muscle in the abdomen actually sort of split apart down the middle as the mother's stomach distends during pregnancy. And we'll see a picture of that also later in these slides. Colostrum is the first bit of milk that moms get whenever they deliver or towards the end of pregnancy. So this is the first little bit of milk that they will be able to express from their breasts. And then we move on to transitional milk and mature milk. All 3 of these types of milk are made up with different types of nutrients. Colostrum specifically has tons and tons of antibodies and provides lots of passive immunity to the newborn. All right, so what is postpartum? Postpartum begins after the delivery of the placenta, and it ends when the body returns to the pre-pregnant state. The postpartum period lasts for about 6 weeks' time, and this is the puerperium period. Sorry, trying to rearrange my stuff here, guys. All right. One thing to note is that during this time for a mother, we provide probably the least amount of medical care to pregnant women during this particular time period when it comes to obstetrics, childbearing moms. And there's actually some new research out that says we do a really poor job of taking care of moms during this time frame because we keep them in the hospital for 24 to 48 hours when they deliver and after delivery, and then we don't see them again except for maybe once or twice if you had a C-section during this entire postpartum period. And we know that the body has to do a lot of work to prepare itself for pregnancy, and it does a lot of work during labor and during delivery. And then we have this whole period of 6 weeks time in which we really don't see mom but like once, and her body is working through all of these changes trying to get back to a normal state. So we don't do a great job really keeping close eye on mom during this period. So when we think about the postpartum period, the first thing that we should think about is postpartum assessment when it comes to nursing. You should be very familiar with the Bubble Heat postpartum focused assessment by now. We know that goes through a breast assessment, a uterine assessment, bladder, bowel, lochia, episiotomy if there is one, Hohenstein, and emotional state. We also gather vital signs. We check uterine firmness, the location of the uterus in relationship to the umbilicus. We check uterine position in relation to the midline of the abdomen, and we look at the amount of vaginal bleeding or lochia. And we'll talk about where those things are placed in just a minute. So, for vital signs, how often should we be getting vital signs? And we have talked about this previously. Many of these standards are set by ACOG, which is the sort of governing board for obstetrics and gynecology. And this is kind of the standard of care across the board for the postpartum period after delivery. So what normally you'll see is in the hospital after delivery, we will get vital signs every 15 minutes times 4 for the first hour, every 30 minutes times 2 for the second hour, and then hourly times 2, and then every 4 to 8 hours after that until discharge. We also should note here that during our postpartum assessment time frames, whenever we're doing the fundal palpation and massage, these vital signs, checking lochia, the immediate recovery time is considered to be that very first hour. So that every 15-minute check times 4 for that first hour is the immediate recovery period for a mom who has delivered. And that's a very important time because hopefully we will be able to recognize any signs or symptoms of a complication that could occur, for example, a postpartum hemorrhage, and be able to stop that from happening. So here again is your focused postpartum assessment. We do breath checks, we check the uterus. We're looking specifically at fundal height, uterine placement, and fundal firmness. Very important to note these things. After delivery, the fundus should be at U, or at the umbilicus. It also should be in the midline of the abdomen. If the uterus is above or to the side, to the right or left, in mom's abdomen, then what usually that indicates is a full bladder. So we're also doing bladder assessment at the same time, looking to see, is the bladder full? Do we need to help mom up to the bathroom? Is the bladder functioning? If mom has a Foley, what's urine output? And then bowel, same thing here. What's the function like? Lochia, color, amount, and consistency, always that's what we want to look at and document. And the episiotomy and lacerations, if mom has either one of those, we want to make sure that we are checking those. And remember that lacerations can occur cervically, they can occur vaginally, and also on the perineum. So we want to be paying close attention to those. Homan sign, because we want to make sure that mom is not experiencing any type of deep vein thrombosis, and we know that pregnant women, especially in the postpartum period, are at a great risk for DVTs. And then always assessing the emotional state and educational needs for mom. So let's talk about change in the uterus. Well, we know that whenever we get pregnant, our uterus goes from about 2 ounces and can expand to almost 2.5 pounds. So we have to shrink that uterus back down after delivery from that 2.5 pounds down to back to 2 ounces where it was before. The umbilicus is our reference point in relationship to the uterus and where it's located in mom's abdomen. And involution is that descent of fundal height. So that's the shrinkage of the uterus going back down to its normal size. Typically at delivery, you can see here, my pen's not working. Hold on. You can see the umbilicus here. At delivery, you can see that the uterus is, the fundus is right there at the umbilicus. And then it goes down about 1 centimeter a day. The cervix, which is also part of that uterine muscle, is very flabby and split-like, and later it begins to firm up and elongate back to its normal structure. Moms also experience afterbirth pains as well, specifically moms who have birthed macrosomiac babies, moms who are breastfeeding, moms who are multips, or who are receiving oxytocics. All moms should receive some type of oxytocic after delivery to help her uterus sort of cramp down and stay nice and firm to prevent hemorrhage. And so that does cause some afterbirth pains. Breastfeeding moms experience afterbirth pains because moms that breastfeed will have a surge of oxytocin from their brain whenever they begin to breastfeed. It's a hormone that's released while moms breastfeed, and we know that oxytocin helps contract the uterus. So that's why moms who breastfeed have worse afterbirth pains. Moms who've had a uterus that has been largely distended. So, for example, with that macrosomiac baby, or moms who have had multiple pregnancies, they tend to have worse afterbirth pains than women with a normal size or a small baby or first-time moms. One thing to note with breastfeeding moms is that if sometimes they will want to stop breastfeeding because of these afterbirth pains. So it's important that we educate them and let them know that these afterbirth pains will only last a few days post-delivery. So really anywhere from about 1 to 3 days, those afterbirth pains will subside. And it's important that we let moms know that so that she doesn't believe that this is how it's going to feel every single time that she begins to breastfeed. All right, so if we have normal involution or shrinkage of the uterus, then where is that at? Well, immediately postpartum, it's in the midline at the umbilicus, and we're talking about the fundus here. 12 hours postpartum, you'll usually find it about 1 centimeter above the umbilicus, and then every 24 hours, it will descend anywhere between 1 to 2 centimeters. On the 6th day postpartum, you should find the fundus between the symphysis pubis and the umbilicus, so kind of midway. And then on the 10th day, you should not be able to feel the uterus or the fundus at all. It should have gone back to very near its normal size. All right, so how do we assess for fundal height? Something that we have talked about at the very beginning of the semester when we did our SIM day. And obviously, we always wash our hands first and explain the procedure to the patient. We want to put on some clean gloves, and then we support the lower segment of the uterus by using one cupped hand and palpate the abdomen to locate the fundus. So right down here at the lower uterine segment, we always want to support that portion of the uterus and then rub with our other hand to feel the fundus here and then be able to locate where it is in the abdomen. We want to document the location, the consistency, is it firm or is it boggy, and the fundal height in centimeters. So is it at U, or is it U minus 1, or is it U plus 2? We want to know exactly where that is, and we want to make sure we document that accurately. The reason that we need to always support the lower segment of the uterus here whenever we're assessing for fundal height is because what we don't want to do is press down to try to find the fundus here and then invert it, which means turn the uterus inside out. So where is the fundus, or where should it be? It should be in the midline of the abdomen. However, if you find it to the side, then that's a good indication that mom's bladder is full and she needs to void. It's important that we ask moms to empty their bladder before a fundal check, because that way we will get a better picture and a more accurate assessment of exactly where that fundus is. And then consistency, meaning is it firm or boggy? If it's firm, then it's well contracted, and we can feel pretty good that mom's body is doing what it's supposed to, and hopefully we won't have any sort of postpartum hemorrhage. However, if it's not firm, then we have some uterine atony going on, and we may see more bleeding, and mom may experience that postpartum hemorrhage. If the fundus is boggy, then your priority nursing intervention should be to massage the fundus to try to firm it up. We want to massage in a circular motion. If mom is breastfeeding, then we want to encourage her to breastfeed, because we said earlier that breastfeeding has the brain to release oxytocin, and oxytocin will help that uterus contract. So if she's a breastfeeding mom, we want her to breastfeed. We want mom to empty the bladder. If her bladder is full, it will not allow that uterus to contract like it needs to in order to stay nice and firm, so it will begin to get boggy. And if we can move that bladder out of the way and we can keep it nice and empty, then we can encourage the uterus to stay clamped down. So we want to make sure we have her void before actually catheterizing, doing any kind of in and out cath. We want to call a doctor. We may have to administer some type of oxytocin or such as Pitocin, Ergotrate, or Methergin. Those are all medications that we can give mom to help firm that uterus up if we cannot get it to firm up by doing a massage or encouraging her to void. Couple of things to note is that oxytoxics can elevate the blood pressure. They cause water retention or fluid retention. They can send moms into water intoxication. And oxytoxics can prevent hemorrhage, so we have to we have to keep in mind what the risks and the benefits are prior to administering these. Methergin is another medication that we can give to help the uterus to firm up and contract, and a big side effect of that is diarrhea. Okay, so just another picture of fundal massage. We know that fundal massage is to help firm up the uterus if it is boggy, and we also know that we will do this immediately in that immediate postpartum recovery period, every 15 minutes times 4 for the first hour, every 30 minutes times 2 for the second hour, every hour times 2 for a total of 4 hours, and then we'll do a fundal massage usually once a shift, so every 8 hours or every 12 hours. We really should be doing it every 8. Moving on, lochia is another thing that we also have to assess as an obstetrics nurse. Lochia is the vaginal discharge that a mom has after delivery. What happens is that the endometrial lining of the uterus has to shed itself off after pregnancy is over. And what we get whenever that happens is lochia. There are 3 stages of lochia. We have lochia rubra, which is a very bright red that usually lasts from days 1 through 3. We have lochia serosa, which is more of a pinkish brown, serosanguinous looking kind of discharge, and that's anywhere from day 3 to day 10 postpartum. And then we have lochia alba, which is a yellow or a white type of discharge, and that's anywhere from day 10 to day 14 postpartum. We can describe lochia amount in a few different terms. It can either be scant, light, moderate, or heavy. So heavy would equal 1 pad in 2 hours time frame. That means completely saturated from front to back. And then excessive would be 1 pad in a 15-minute time frame. That would be very excessive, and I would really question whether or not that mom is having some type of postpartum hemorrhage if she is bleeding excessively enough to saturate a pad in 15 minutes. Sometimes heavy bleeding will occur directly after delivery, and one thing that we need to note about that is, what does it look like? What's the consistency? Are there any clots coming out in that lochial discharge? And if it's just some normal heavy lochia rubra, then what we want to do is just keep a close eye on mom and ensure that the lochia is appropriate in color, odor, consistency, and amount, and rule out other problems. Now, if her heavy bleeding moves forward into excessive bleeding, then we may have an issue with a postpartum hemorrhage. But many women will have heavy bleeding after delivery. We just have to keep a really close eye on those moms. And we would also be doing other types of assessments to go along with that heavy bleeding when we're keeping a close eye on them, such as paying very close attention to their vital signs to make sure that there aren't any other signs or symptoms of hypovolemic shock. This is a picture of some abnormal lochia. You may not see that in this picture, but any type of lochia that has very large clots is abnormal. A foul odor can indicate infection. Those very large clots and an excessive amount of lochia can mean that there are some retained products of conception that have been left inside the uterus. Rubra past 3 days usually can indicate that there are some retained products of conception there, and possibly a late postpartum hemorrhage. So this is why it's very important that we educate our moms really, really well, because obviously at past 3 days, mom is going to be at home. She will not be in the hospital. So we have to be really cognizant of how well we educate and making sure that they understand. And then extended serosa or alba type lochia can indicate that there is possibly some type of endometriitis going on. So here's a little chart that shows you the differences between rubra, serosa, and alba. Rubra is red, usually lasting 1 to 3 days, and composed of blood, mucus, and part of the decidua, or the endometrium. Serosa is pinkish in color, happens from days 3 through 10 postpartum, and it's composed of blood, mucus, and leukocytes. And alba is white, and it occurs days 10 through 14 postpartum, and it's composed of mucus and leukocytes, so the blood should be gone with alba. A cautionary thing to note here is that moms who have a return of lochia rubra with signs and symptoms of infection, that can indicate that there is some subinvolution going on, possible postpartum hemorrhage, and or endometriitis happening. And those are things that would need to be reported back to our doctor. So what about the vagina and the perineum? Well, obviously things are going to be very swollen and edematous. If there's an episiotomy site, we may see bruising and there will be tenderness. Mom may have lots of swelling at that site. There possibly could be signs and symptoms of infection there. There may be a hematoma that starts to form. Same thing with the laceration site, and we have to remember that these couple of things are very uncomfortable. Repaired sites have to be approximated and intact, and we definitely want to document that. So if we're assessing an episiotomy or a laceration on a mom's perineum, vagina, or cervix, we want to make sure that things are approximated and intact. And we want to assess for RETA. That is your acronym for redness, edema, ecchymosis, drainage, and approximation. We want to make sure that moms have as much comfort as possible in the perineal area. And there should be no solid mass or no complaint of perineal pressure or pain after delivery. If your mom begins to complain of a solid mass, or if you see a solid mass, or she begins to complain of perineal pressure and pain, it's a good indication that she may have a hematoma starting to form. And you may not always see a hematoma, but it's important that we always are looking and assessing their perineal area very closely after delivery, because a hematoma can hold a very large amount of blood, and your mom may start experiencing signs and symptoms of hypovolemic shock in terms of vital sign changes, and you not see any extra bleeding and miss that because you don't know that there's a hematoma forming. Epidural patients may not experience or complain of this pain or pressure in relationship to a hematoma, and so vital signs would be your very first clue that there's something going on with those patients, because they may still be numb in their perineal area. Another reason why it's very important that we are visually assessing and documenting RETA. Surgery might be indicated if moms are having severe hypovolemic shock and those signs and symptoms are evident, because that may be the only way possible to stop any type of postpartum bleeding if it is occurring. There are a few ways that we can help ease the pain in the perineum post-delivery. Initially, we want to apply ice packs. So for the first 24 to 48 hours, we want to give mom some ice packs to put on her perineum, and that helps the swelling go down. And then after that, we want to apply heat and warmth. So we want to assist the client to take a hot sitz bath. This little picture here is what a sitz bath looks like. It's something that sits in the toilet seat, and you almost looks like an enema bag with a tubing. You fill the hat up with warm water, and you fill the bag up with warm water, and you attach the tubing to the inside of this hat that goes in the toilet, and then open the clamp up, and the water will flow from the bag into the hat and almost make like a little whirlpool for mom's perineum. And it helps circulate warm water around her perineal area and help increase blood flow and speed up healing. Topical anesthetics or witch hazel are very good at relieving discomfort. So things like Dermoplast, that's usually one of those spray medications that mom gets in the hospital. You can also get it over the counter, and it works really well on the perineal area to sort of numb up that place, especially if she's got an episiotomy or a laceration. We want to make sure that moms are keeping their perineum clean and dry. We want to make sure they're wiping from front to back because we don't want them pulling any type of bacteria from the back to the front, especially up through a fresh incision site or a laceration that's been repaired. Again, warm water to clean the perineum with, making sure moms are changing their perineal pads as often as possible. We don't want them to reuse any peri pads. We want them putting a clean pad on every time that they go to the restroom, and we want them changing them often. Sometimes oral medications will also help with the pain and discomfort in the perineal area, so things like Tylenol, NSAIDs, and possibly opioids as the doctor prescribes. Stool softeners are very important as well to help prevent constipation. When moms have had episiotomies and lacerations and they have stitches, it's very difficult for them to want to bear down to have a bowel movement. So the softer we can keep their stool, the better for them and the less likelihood that they will end up with some constipation in regards to not wanting to go to the bathroom. So things like Colace and milk and magnesia are really good for moms post-delivery. All right, so the abdomen. The abdomen will be stretched and loose, have some flabby skin post-delivery. You may see diastasis recti abdominis, and that's where I told you that those muscles right here in the those abdominal wall muscles will split kind of right down the middle whenever you are lying flat, and then you go to sort of sit up as a mom that has this condition, diastasis recti. Basically, those muscles have split, so what you see here is almost like a little hump in the middle of their stomach. And this can be corrected with exercise. It just takes a while to do. With a C-section, when we're assessing the abdomen, we want to make sure that we are assessing the incision site and documenting that. We know that there are two types of C-section incisions. We have that low transverse and the classical. Striae may change in terms of color, and they may fade, but they will not disappear. Bowel sounds in mom may increase or decrease depending on how she delivered. If she's a C-section, she may have decreased bowel sounds because we've done a lot of manipulating intra-abdominally during surgery. If she has delivered vaginally, you may find that her bowel sounds are very increased because she's extremely hungry and thirsty. In terms of the breasts and breastfeeding or milk making, lactogenesis, we know that prolactin is the hormone that stimulates milk production. So moms will begin to release prolactin from the brain. Oxytocin is that chemical in the brain that will stimulate the milk let down reflex and ejection. So this is actually what causes mom's milk to come down through the breast and be ejected. There is something that goes along with breastfeeding called the feedback inhibitor of lactation. That's the FIL, and it is a negative feedback system. So in other words, breastfeeding works on a supply and demand type system. The more the baby feeds, the more milk that is supplied and ejected, the more milk that mom will make. The less milk that mom puts out, the less milk she will make. When mom's breasts get very full of milk and it doesn't go anywhere, then her body sends a system back to the brain, and it says, okay, we've got plenty of milk in our breasts. We don't need you to make any more. Okay, so prolactin, you need to slow down. We don't need you anymore. However, once mom feeds her baby, and the more often that she feeds her baby via the breast, then her body lets that milk down and lets that milk out, and her body tells the brain, all right, start releasing some prolactin because all my milk is gone and I need some more. So it works through a negative feedback system. Foremilk is the first milk that comes out as a baby begins to nurse. And hind milk is the milk that comes out last. So there's sort of two different consistencies in those two milks that come out at the same feeding. Foremilk is more like a skim milk, sort of, and hind milk has all of the fat content and more of the calories in it. So whenever we're teaching moms about breastfeeding, it's really important that we encourage them to allow the baby to finish the feeding on one side before moving the baby to the next side. Because if babies are only getting that foremilk on one breast and then they're moving to the next breast and only getting the foremilk from the next breast, then they're going to be gassy, and they're also not going to get full because they're not going to get all that fat content and the calories from the hind milk. After lactation is established, colostrum milk is very high in immunoglobulin, so it provides that passive immunity to a newborn. It has protein, it's low in fat and carbs. Transitional milk, so that milk that happens in the body between colostrum and mature milk, has more fat, it has lactose, some water-soluble vitamins, and calories. And then mature milk is about 13% solids, so carbs, proteins, fats, and then about 87% water. Another thing to note when assessing the breasts and breastfeeding is that breasts can get engorged. That means that they become way too full, and this is very uncomfortable for mom. So we have to know how to mitigate engorgement for moms who are breastfeeding and for those who are not. And here's your checkpoint. What are the benefits of colostrum to the newborn? And we've already talked about this a little. Colostrum is high in immunoglobulin, so it provides that passive immunity to a newborn. All right, so engorgement. In the cause of engorgement is a stop in lymphatic circulation, and then what happens is the veins become congested and block milk production. So milk gets stuck in there, for a lack of a better way to say it. The breasts become way too full. The letdown reflex doesn't work properly, and moms can end up with a reddened area like this. Her breasts might look very swollen, and this can also turn into mastitis, which is an infection of the breast tissue, and that comes along with some flu-like symptoms. Moms will run a high-grade fever, their breasts will be sore, they may have that sort of reddened area like in this picture. So it's important that we keep a check on this. If mom is not breastfeeding, then what we don't want her to do is we don't want her to express any milk if she becomes engorged. We want her to bind her breasts up. She could use cabbage leaves. Cabbage leaves have some type of enzyme in them that will help draw out breast milk without actually utilizing that letdown reflex that the body has. And this way, mom's body will not tell the brain to continue making milk or to make more milk. So if moms are engorged and not breastfeeding, we do not want them to express that milk out, because that will tell her body to make more milk. However, if she is breastfeeding, the best advice we can give her is to continue to feed the baby on that side, to apply some warm compresses to sort of hopefully help increase the blood flow there and stimulate a letdown reflex. If mom is not breastfeeding, instead of warm compresses, she can use ice packs. Cracked nipples are also a breast problem that you may see whenever assessing the breasts. And if you see cracked nipples, we want to make sure that moms have ointment for those cracks, and we want to make sure that she's keeping things clean and dry. And we also want to warn her that mastitis is also a possibility whenever you end up with cracked nipples. So anything that inflames the tissue or creates a portal of entry for bacteria can put mom at a greater risk to end up with mastitis. And moms with mastitis can still continue to breastfeed. It does not infect the milk or anything like that. You can still feed your baby. The best way to prevent breast problems is correct latch-on for baby. To make sure that you're washing your hands prior to feeding, making sure that you're breastfeeding on demand, so not trying to put the baby on a schedule, allowing the baby to feed on demand allows the body to be able to produce milk in just the right amount for the baby, not too much and not too little. And then obviously correct breastfeeding techniques, correct latch on, and a snug, tight support bra also will help to prevent breast problems. So what happens to hormones after delivery in the postpartum period? Well, moms end up with a decrease in estrogen and progesterone. Remember, progesterone is our pregnancy maintenance hormone. That's what helps us maintain our pregnancy. So once the pregnancy's over, then we have a decrease in that. We have decrease in human placental lactogen. Obviously, because we've delivered the placenta. It's no longer part of our body, and it's not creating that hormone anymore, so it makes sense that it would be decreased. However, we have an increase in prolactin for breastfeeding moms because their bodies need to be making that milk. So if they're letting milk out, then through that negative feedback system, their body says to the brain, I need some more milk, and prolactin is released. Our non-breastfeeding moms, they will have actually a decrease in prolactin because they will not be expressing milk, and their bodies will tell the brain, hey, we got enough milk in the breast, we don't need any more, don't send any more prolactin out. All right, well, what about the gastrointestinal system? So, moms who, sorry guys, my whole leg is going to sleep. I got to move around a little here. All right, so moms have some changes in the gastrointestinal system after delivery. They are very thirsty. They are very hungry. That whole mechanism is triggered, and they end up with a severe increase in appetite. They may experience some constipation, partially because they may be afraid to go to the bathroom postpartally, like we talked about with the moms who have episiotomies or lacerations. And also, they may experience constipation because if they're C-section, then we might have manipulated their bowels to the point that they're sort of in a little shock. If they're vaginal deliveries, they may have received, both vaginal deliveries and C-sections, they may be receiving some type of narcotic pain medication that is slowing the GI system down. Flatulence also occurs in the gastrointestinal system in the postpartum period, specifically for C-sections, for whom that we have cut open their abdomen, and now we have all that air in there, and it has to dissipate somewhere. Hemorrhoids are also an issue. Moms have carried lots of weight around in their belly for 9 months' time. It's pressed down and caused a lot of pressure in the perineum and on those veins in that area, and those moms may have hemorrhoids. Bowel sounds should return after a C-section, and it's important that we are assessing that return of bowel sounds. And then obviously there are some change in patterns of the GI system due to possible pre-labor diarrhea, dehydration, episiotomies, lacerations, moms that are NPO, drugs, and then the use of instrumentation during delivery, such as forceps and the vacuum. With the urinary system, postpartally, we, as mothers, we experience a huge amount of diuresis, and we're usually diuresing 2 to 3 liters per day, which is a huge amount of fluid. But if you think about how much fluid we build up over that 9-month period, it's got to go somewhere. And so that's why we see this postpartum diuresis. Our bodies have got to get rid of all that extra fluid circulating around. And that's one reason why urinary retention can be very dangerous to postpartum moms. And that can occur because of trauma, maybe related to a C-section or a tumultuous delivery, because of medications such as Pitocin, loss of bladder tone in regards to a C-section or a tumultuous labor, and then possibly anesthesia. A full bladder also can displace the uterus over to the side, meaning that now it's not in midline where it's supposed to be, and that can cause the uterus to not be able to cramp down and stay firm, and in turn then we end up with a postpartum hemorrhage because that uterus is not able to contract in regards to the full bladder. If moms are not able to freely void when they need to and frequently, then they may need an in and out catheterization. We may have to institute bladder hygiene and training for moms who've got some bladder tone issues. Dilated ureters and renal pelves can last 6 weeks or more. And always we want to be documenting the COCA of urine, especially the first void postpartum. Proteinuria and ketones may also still be present in diabetics probably 4 to 5 days postpartum, and that's due to the fat breakdown. With the cardiovascular system, we end up with a decrease in blood volume, partly because of the diuresis that moms are experiencing. We have sensible water loss through urine, fluid shifts, and an empty uterus. And then we have an insensible water loss through sweat and respirations. Remember that during labor, moms will sweat and their respiratory status will change. So they're going to be blowing off a lot of condensation, and that's that insensible water loss. And then also in the postpartum period, many women will have postpartum night sweats. And the reason that they have those is because they're still getting rid of fluid that has piled up in the cardiovascular system over pregnancy. The uterus is empty at this point, so we end up with a decreased venous pressure in the lower extremities. Another reason why these moms are at risk for deep vein thrombosis. All that fluid, blood, and urine loss also equals a weight loss for mom. Hooray. But we have to pay really close attention in the first 24 to 72 hours postpartum because of the increase in maternal systemic circulation. How do we help prevent thrombophlebitis for these moms? The easiest and the most effective way for us to prevent thrombophlebitis in postpartum moms is to ambulate them, and really for anybody, is to ambulate them as soon as possible after their vaginal delivery or as soon as possible after their C-section. We want them up and walking around. We want to assess and document Homan sign, inspect the leg for redness, swelling, and warmth because that's an indication that there's a venous thrombosis forming. We want to apply TED hose and SCDs as ordered by the doctor. There may be Lovenox shots to be given or other types of anticoagulant meds that mom is prescribed by the doctor, and we want to monitor lab results. In the musculoskeletal system, what we find postpartally is that moms are very fatigued. They have muscle aches due to exertion during the second stage of labor. They're exhausted because of the labor process, first, second, and third stage. Their center of gravity will begin to return, and that's painful too. When you've got a mom who has walked around with some lordosis for probably 7 months or so, it is painful to have all of that delivered and then have to readjust your center of gravity again. So it's important that we help mom understand this, and also another reason why ambulation is good during this point. Rectus abdominis may separate due to an overdistension of the uterus, and we saw a picture of that earlier. That's what's called the diastasis recti abdominis. By 6 weeks, the relaxed bone joints in mom should return to their pre-pregnant state. But with C-section moms, we want to ensure that they delay any type of abdominal exercises because we do not want them to end up with a dehiscence of their wound. Vital signs. We get changes in temperature. Sometimes mom's temperature can elevate up to 100.4, and that's pretty common, and one reason is because of the stress that labor and delivery puts on mom's body. Blood pressure will rise briefly just after delivery, and then it begins to return to baseline. However, if it does not, that is an abnormal finding. Orthostatic hypotension might occur. Moms have been lying down for long periods of time, so we have to remember that once they start to get up, sit up on the side of the bed, or stand up at the bedside, they may experience some orthostatic hypotension, and then they're at risk for falls. So we have to pay close attention. Heart rate, 50 to 70s is common, but anything over 100 is usually considered abnormal. That could be a beginning sign of postpartum hemorrhage or possibly infection. Pain level varies for moms, and we should know that because pain is a very subjective sign and symptom. So fatigue is something that we usually find with all moms, and we want to help encourage her to rest as often as she possibly can. And moms might complain of a headache. They haven't eaten in a long time. They might complain of incisional pain or leg pain, and we want to be assessing and paying attention to all those complaints. Laboratory values. White blood cells tend to be up, and anything up to 30,000 is acceptable if there's no infection. The way that we know that there is an infection usually is if mom is running a fever, or she's got other signs and symptoms of infection, such as her wound looks infected, or she's experiencing some, maybe had an infection during labor or before labor. However, the stress of labor and delivery will actually cause your white blood cells to increase. So it's important that we know that so that we don't freak out whenever we get the lab results after delivery, whenever we've drawn that CBC on mom. We have to know that it's normal for them to be increased slightly, and we want to just continue to monitor and make sure that no infection develops. Also, moms have hemoconcentration due to their extracellular fluid loss, and that happens for up to 72 hours. Another reason why they're at great risk for deep vein thrombosis. After about 3 to 4 days, the CPV rises, and there's a decrease of hematocrit and hemoglobin and plasma protein. Another reason why they're at high risk for DVTs. And here again, they have high coagulation factors, high fibrinogen, which we know is a clotting organism. The blood coagulation system will usually return back to its normal state about 3 to 4 weeks postpartum, but the deep veins in their legs will remain dilated for up to 6 weeks. And so if we have all of these high coagulation factors, high fibrinogen, we have hemoconcentration, and now we've got dilated deep veins, that means we're at a really high risk for those DVTs. And you think about that. If your deep veins are dilated, then they have a harder time getting all of that blood back up to the heart, as opposed to if they were constricted. So that blood begins to pool down there, and then mom may end up with a deep vein thrombosis. We also have to pay attention to their immune status when it comes to the rubella titer. If it's negative, then mom is going to need some MMR, because remember, that's a vaccine we cannot give during pregnancy, because it's a live vaccine. So she's going to need that prior to going home. Also, hepatitis B titer. If she is susceptible to hepatitis B, then we may want to give her some Hep B before she leaves as well. And again, here with the RhoGAM, if mom is Rh negative and the baby is positive, then she needs some RhoGAM within 72 hours of delivery.
What are our losses and gains? So, pregnancy weight gain of 25 to 35 pounds is usually common, sometimes more than that, sometimes less, depending on your patient. And then after delivery, we've got an immediate weight loss of 10 to 12 pounds, and then later on in the postpartum period, up to possibly 19 pounds. The family has expanded, so we've got some gains there. We've got a new member of the family, and now everybody's got to figure out how to adapt to this new person. We've got the gain of a joy of parenthood, or possibly not if this was an unwanted pregnancy, so something to consider there. The reproductive cycle for a mom will begin to return. If she's non-breastfeeder, it'll begin to return in about 190 days, but with the breastfeeder, about 2 months. Stretch marks start to fade out. The linea nigra probably will remain. Some moms may experience hair loss, and this is not definitely an all-encompassing list of all of the losses and gains that occur in the postpartum period. But these are a few that I wanted you to, start thinking about, and, think about all of the different other types of losses and gains that moms and families will experience. They lose their freedom to a sense. They will, in some form, maybe a little bit, lose their independence. They lose that past life that they had. So we want to be cognizant of all those things. Okay. I believe that we will stop there for now, and return with Lecture 2 and begin again, starting to talk about psychological adaptation. Thanks for listening, guys.